To our Citybiz audience, welcome to Citybiz CEO Interviews. I'm Dave Johnson, and today I'm joined by Dr. Ira J. Gottlieb. He's the founder of the Chesapeake Research Group, and he's a distinguished foot and ankle surgeon, over 30 years of experience. And Dr. Gottlieb has dedicated his career to providing comprehensive care and relieving pain for thousands of patients, and has spent the last 2 decades, and this is important, committed to research and development. Listen to this, focusing on non-addictive, non-opioid medications for pain relief associated with foot and ankle issues. It is such an important topic. Dr. Gottlieb, welcome to Citybiz CEO Interviews. It's great to be talking about this topic and how we can make life better.
I am ready. I'm so excited about this topic that I look forward to talking with you and sharing these facts with the audience.
All right. You just heard me. Yes, no, and it's terrific. The Citybiz audience is found. I just mentioned the Chesapeake Research Group. What was your background and the motivation to start the Chesapeake Research Group?
Well, I've always had a keen interest in the treatment of pain, and I'm a board-certified foot and ankle surgeon, as you mentioned. And basically, they sought me out. One of the research companies sought me out as someone who would be an appropriate person to share my knowledge and to work with them on the development of a new way to test pain medication, and that is through the surgical correction of bunion deformities. It turns out this is a great model, a great surgical procedure that we can use to test how effective medications are in that first 48 hours after surgery.
Wow. First 48. That's an impressive stat right there. And you just kind of touched on it, but when we're talking about the most common foot and ankle problems, what are they that people experience, and how do they impact daily life and overall well-being? You just mentioned bunions, but what else would you like to discuss there?
Well, foot and ankle surgeons basically treat all sorts of conditions, everything from heel pain and plantar fasciitis, sports injuries and fractures, and then, of course, surgical correction of foot deformities like bunionectomy, like bunion deformities and toe deformities, et cetera.
All right. Now, when we mentioned bunions, we all probably know about bunions, but let's dig deeper into this, so to speak. The factors that contribute to the development of bunions, and when is bunionectomy surgery necessary? I don't even know if I pronounced that correctly. It's a mouthful, but when is that necessary, and what contributes to the development of bunions?
So contrary to the popular belief that shoes are the greatest factor affecting the formation of a bunion, it's really not the case. This particular trait is passed down from family member to family member. So it is an inherited trait. How else would we explain what are called juvenile bunions when a 7 or 8 year old has a bunion deformity and they really haven't been wearing anything but appropriate shoes up until that age? So the inherited trait is primary. Secondary factors can be shoes, occupation, the amount of standing that you do at your job, et cetera.
So the number one though is inherited.
Yeah, it's a trait that's passed down from family member to family member. I'm actually living proof, because in my family, my mother, my children's mother, and grandmother, they all had bunions. And so in my family, both my son and my daughter had the deformities, which we ended up dealing with when they were in high school.
All right. Well, then that's great knowledge for all of us to know. We can check our family history when it comes to that. So then when is bunionectomy surgery necessary? When do you go to that degree?
I think when individuals are having difficulty with activities of daily living, just literally the activities of either working or walking or exercising, the inability to wear shoes comfortably, and it just gets to a point where it's an annoyance. It is painful, it aches and throbs, but at that point, patients approach me about their options for surgical correction.
Yeah, well, no, again, when it starts to impact your enjoyment of life, that's important. And then if you have the surgery, pain management afterwards can be complex, especially when we're talking about, and this is so important, with concerns about opioid use, because we want to relieve the pain. So what makes it challenging when we get this relief from the bunionectomy surgery, and how do you balance effective pain relief with the need to avoid opioid dependency. That sounds like a tricky balance.
It is, but we've learned over the years that no single agent, no single medication is the pure answer to treating pain after surgery. What we've learned is it really takes a combination of medications, using even some of the over-the-counter simple medications like Tylenol or Advil or Aleve. These are all products that are available, and we use both of them in combination, which many people don't realize. You can take Tylenol and one of these non-steroidal medicines like Motrin at the same time. And then that way you have something to take every 3 to 4 hours, which is great. So up until recently, we had been using opioids as sort of the third option. Well, do you want me to get into the research that we're doing and what are some of the headways that we've made in developing medications that can add to the treatment paradigm?
Yeah, no, I think that would be great to hear, because this is when we're talking about, and that's what you're doing at the Chesapeake Research Group, correct?
Correct. So I work with pharmaceutical companies who are working with the Food and Drug Administration in development programs to find the effectiveness of these medications. Are they warranted for approval? And the bunion surgery has proved to be truly their favorite bone model, if you will, their favorite surgery. And what we do is volunteers come to my practice. They want to have their bunion corrected, and we mix my surgical expertise and the usual surgical protocols and mix in the testing of a medication. So as an example, if you'd like, we are currently working on anti-inflammatory medications like the Motrins and the Advils, and we are coming up with improved formulations so that these medications are now approaching opioid-like ability to relieve pain. So that's one area. Another area is we're working with local anesthetics, numbing agents. The numbing agents we have in the market, they may last between 2 and 12 hours, but imagine having local anesthesia during your surgery, which will keep you comfortable for 24, 36, 48, even 3 days after the operation, which at that point, the pain level is very minimal, and it can easily be treated with just over-the-counter medications, and oftentimes eliminating the use for opioids at all.
Well, that to me, the takeaway, that's very dramatic of what you're doing at the Chesapeake Research Group, that if you're developing options that are opioid-like, but not opioids. And so that seems to be a tremendous breakthrough. Am I reading that correctly?
You are. So thinking about approaching the opioid power, the opioid-like ability to relieve pain, but not using an opioid. So there are other products which are interesting. There are what are called small molecules, and we've done some studies on those. They simply act as almost like a roadblock so that any pain signals are blocked from going from your periphery, in this case, the foot, up to the brain. So there are pain signals, but they don't reach the brain, so you don't have pain. Quite dramatic. There's a large study going on right now on that particular product. We've also used some of the, go ahead.
No, go. Well, I was just going to say, and also, as you said, you're working in, obviously, concert with the Food and Drug Administration, but they like, you mentioned that it's their, did you say favorite model surgery? How did you describe it with regard to bunions? Because that seems very important.
Sure. Well, prior to what we call the Bunion model, and anything that we use that involves surgery to test medications to relieve pain after, they're called models. So prior to the bunionectomy model, which has been around now for about 25 years, oftentimes the studies were done on patients who needed knee replacement, hip replacement, more advanced surgeries that are more likely to develop complications in an older population and hospital-based. So we had the idea of coming up with an outpatient surgery, a procedure that takes less than an hour, and our patients are healthy, very healthy, and the ages range from early 20s up to folks in their 80s. So the bunionectomy model is a predictable model to test these pain relieving medications. So, as a podiatrist, it was very fortunate that they landed on the bunionectomy model as sort of the go-to model for relieving pain.
And important because, again, as we just discussed, you want to have options that are opioid-like but not opioid, because it just when you can share with us some of the consequences if people do become dependent on opioids, that's a road you don't want to go down. How can that impact a patient's life?
So, I mean, opioids are devastating and they're deadly. It affects individuals, it affects families. And, in medicine, in treating pain in the United States, we were using opioids to a much greater degree than was the case in Europe, per se. So, the number of deaths that have occurred in the United States over the last 20 years is up about 800%. And so every 10 years, it was, say, in 2000, 2001, it was about a certain number. It was, I think, about 8 to 10,000. Then it went up to 4,000. Well, now it's over 8,000. I'm sorry, 80,000, 80,000 deaths from opioid use. And, opioids cause lots of different side effects, but the deadliest is your breathing center is suppressed. And so you take too much opioids, then your breathing center doesn't signal your body to actually inhale and exhale. And so you stop breathing. And that is what causes, sadly, the death associated with an opioid overdose.
Well, and then that brings us to why it's so effective to have non-opioid pain management. What are some of the methods that you're recommending to your patients that are non-opioid approaches that differ from, the old opioid pain relief model?
Sure. So in medicine, we use the term multimodal therapy, meaning we're using many different medications to attack the painful condition. And as I've already mentioned, Tylenol is a great addition to that lineup. And ibuprofen-like drugs are also effective. And now we're creating even stronger anti-inflammatory medications like Motrin, and they seem to have a great benefit in relieving the pain, so that ultimately, if opioid medication is still needed, the amount is shrinking so much. And as I said, in the ideal situation, we hope to get to the point where we no longer need to use opioids at all.
Well, and the great thing from what you're saying, it seems to me that if you work with your doctor, you could be given recommendations of things you can easily buy and use together, if I understood that correctly, the Tylenol, the Motrin, that type of thing.
Yeah, and inexpensively. So as I mentioned earlier, if we get these local anesthetics working longer and longer and safely, it will basically mask the pain during that 48-hour period, which is the most intense. So they're great. The anti-inflammatory medications, we're using those that are absorbed more quickly, so the blood levels are higher and it relieves more inflammation and pain. So we're not just attacking it in one way. It's a multimodal approach, different types of medicines, some created by man, some already found in nature, some that are off the shelf in your local supermarket. And I know we're on to something. We're starting to just see a little bit of a drop in the number of opioid deaths as this situation has become so commonly understood as truly an opioid epidemic.
Well, and I can see the smile on your face because you can feel progress being made, and you're attacking this creatively and relieving people's pain. So what is going on with the Chesapeake Research Group that it's so exciting? Just as we've enumerated so many developments that are happening. So then what should patients expect when they're participating in a research study at the Chesapeake Research Group? And how do we get interested, individuals that are interested that might want to go down this course of action?
There are multiple reasons why participating in a clinical trial, such as a bunion removal clinical trial, are beneficial. So the advantages are that the participants do not have to pay for any of their medical care. And in today's world of higher deductibles and increased copayment amounts, people who have good insurance all of a sudden are facing $8,000 and $10,000 expenses out of pocket. So that's one way to get this care performed at no cost. And then on top of that, because you're a volunteer, you will be paid for participating. And the payment can be $1,000 or more. So how does this get even better? Well, you get an experienced surgeon like me to take care of you, who's performed over 3,000 bunionectomies. It is truly my expertise. And you're helping us attack the opioid epidemic. So what's the downside? What is the catch? And there really is no catch. The only catch is you're helping us just determine if these products are effective or not. So it really is a win-win-win for everyone. It's just trying to get the word out so that this is a great way to go to solve a problem that's annoying to many people, and to do a good thing for the public, and to save some money and get paid.
Get paid. I think it's win-win-win-win. There's at least 4 or 5 wins in there. That's definitely a championship formula with the Chesapeake Research Group. Again, getting paid, it doesn't cost you anything. The experience, doctors, like, again, 3,000 bunionectomies. Wow. I'd say Dr. Ira J. Gottlieb is a master surgeon when it comes to that. And again, it's so important. It's been a theme of our conversation today here on Citybiz CEO interviews. We want to combat the opioid crisis. So I tough question now for you. I want you don't have to get out a crystal ball, but how do you see the future of pain management, particularly after foot surgeries? And I know it's some of what we already talked about, but now put it all together. How do you see the future of pain management?
So I think the future will involve, while in surgery, administering products that can prevent the pain signals from erupting, if you will, for a long period of time. So it starts intraoperatively. And then after surgery, we will be using anti-inflammatory medications, which have proven to be really helpful for many different types of aches and pains. But these prescription ones are really climbing the ladder as far as knocking down pain. So you put something in that's not an opioid during surgery. You take an anti-inflammatory medication or a mixture of anti-inflammatory medication and Tylenol. You're really controlling the situation. And at that point, if there is still some breakthrough pain, maybe an opioid will be needed until we get through maybe another 5 years of research or so. But I'm hoping, and I've experienced in my studies, individuals who over a period of 3 days have taken only Tylenol after bunion surgery, only Tylenol. And if they're using opioids, they are using maybe 2 or 3 over a 3-day period, as opposed to, in years past, 40 hydrocodones or 40 Percocets. We're no longer near prescribing that amount of medication. And, medicine needs to take some of the onus of the problem. It's easy. You just give people opioids and it takes care of their pain, but it causes so many other problems that, we're on the right track now.
Well, yeah, I never thought I'd say this, but I'm feeling good about pain, or at least pain management, of what the Chesapeake Research Group is doing. And again, Dr. Gottlieb, you talked about win-win-win. It doesn't cost anything. You're actually paid. Experienced surgeons in combating the opioid crisis. Getting involved in the Chesapeake Research Group, that is something that you might want to consider. Is there anything else you want to add that I might have forgotten to ask you?
No, for people who are maybe a little apprehensive about participating in a clinical trial, routinely when I see an individual for this problem, I will correct, say, the right foot. But they usually have the problem on both feet. Inevitably, people come back to us. They participate in another clinical trial to get their other foot fixed. So you have win-win-win-win bilateral.
This has been a win, spending some time with you. And again, Dr. Ira J. Gottlieb, thank you so much for your time and all the work you're doing with the Chesapeake Research Group.
It is a pleasure. It's challenging. It's fun and it's interesting, and we're making a difference. So thank you for your time and helping us spread the word.
Yeah, and that's that last word, your last phrase, making a difference. The Chesapeake Research Group are indeed doing that. And we thank you, all our Citybiz audience and viewers, for your time, because time is the most important thing. We appreciate it. I hope this will be of some use. And yeah, I know I'm going to call my relatives and see if they have bunions, because I found out today it can be hereditary. So again, it was great sharing this as part of our Citybiz community. I'm Dave Johnson, and we'll see you next time.
Great. Thanks so much, Dave.